Hello, welcome to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode, I'm joined by Andy Bell, Deputy Chief Executive at the Centre for Mental Health, and Marsha McAdam, Mental Health Advocate and Peer Ambassador for the Centre. Andy and Marsha talk about the impact of Covid-19 on mental health and the importance of taking this opportunity to really think about how people's mental health needs should be met, as well as recognising new needs that may have arisen as a consequence of the pandemic. Covid-19 has exacerbated many existing inequalities, with the pandemic affecting some people much more than others. As the NHS and wider care sector re-establish services, Marsha and Andy argue that resources and attention must be focused on those who most need support. So, Andy and Marsha, thank you so much for both joining me today to talk about the impact of Covid-19 on mental health. Could we start by just both introducing yourselves, if you want to go first, Marsha?
I'm Marsha McAdam. I'm a mental health advocate and I'm also a peer ambassador for the Centre for Mental Health.
I'm Andy Bell. I'm Deputy Chief Executive at the Centre, and we're an independent organisation that seeks to improve policy and particularly reduce inequalities in mental health across the country.
Thank you. So the idea of today's podcast is mostly to talk about what we've learned and think about we need to do in the coming months and years. But I wonder if we could start by just briefly looking back. And Marsha, could you tell us a bit about your experiences or what your experiences have been over the last few months during the pandemic in terms of accessing services and getting the support you would normally get?
I'm one of the lucky ones. I have mental health and domiciliary care support, and I'm definitely one of the lucky people. But that was only because I went through quite a few bad things before, and at the minute I have care by a city council in-house team who are looking at both the physical and the mental health part of me, and that's basically what's kept me well in the last few months. So and that has actually been acknowledged by my community mental health nurse, that if it wasn't for the package, that I would have no doubt been in hospital. So, yeah.
Oh, that's good to hear. I imagine it hasn't been the same for everybody though, Andy.
No, I think, it's very, very mixed, and responses have been different in different areas of the country. But I think certainly what we're hearing anecdotally from a lot of people is that they do feel that services have either not been there for them or have retrenched or have become much more difficult to get access to. I think it's also really important to say that mental health services have tried to be there for people. They have, a lot of them have shifted their support online. They've had to extend their offers that they can do remotely by phone. But it is incredibly challenging. And I think what we're hearing from a lot of people is that they are struggling to get access to help, and particularly help with the basic things in life, food, medication, money coming in. These are all things that are really important foundation stones for mental health, and they're just as important as getting the psychological support.
And one of the things that's been mentioned is that the focus on addressing Covid-19 might have had an impact on the parity of esteem in health and care between physical and mental health. Do you think that's the case?
I think that there's a risk of it happening. So far there's been a recognition that mental health is an important part of the care and support that people should get. And there has been recognition, particularly of the mental health challenges facing staff, particularly in hospitals. Sadly, I think there's been less focus on people working in the voluntary sector and social care. And as Marsha has already demonstrated, actually the best care comes when you bring those together. But I think there is a real risk that as time goes on, we've just heard £3 billion announced for the NHS in winter. There's not been comparable funding for social care over that time to come, and how much of that money will go into mental health support, because we will really, really need it then. Whatever happens, we're going to have heightened mental health needs as a result of this pandemic, and actually we need parity more than ever right now.
I'm on one of the lived experience on the Equally Well campaign, and we, just before all this happened, we were actually looking at really the parity of esteem and marrying it all up together. And unfortunately, with COVID happening, that had to we weren't able to all meet. That had all the key people around the table, with the most important lot in the middle, which was the patients. So sadly, that was not able to happen, but it's something that I know that Andy and others want to make sure happens, carries on the way that we were going.
Yeah. No, absolutely. And it's something that's been raised by quite a few of our members, is that that's one of their concerns, is that potentially just the focus on the acute sector might mean that focus elsewhere drops a little bit. So it's great to hear that there's still work going on that.
There is undoubtedly a risk that happens, and I think the way that this emergency funding gets used will be very telling as to whether actually there is a recognition that you have to support people's mental health through this. And that means both supporting people with mental health difficulties who we know have struggled more through the pandemic than most. It also means meeting the needs of people who have extra mental health needs as a result of it. So people that have been bereaved, people that have been treated in hospital, family members who've been treated for the virus, who we know have a greater risk of poor mental health now. And so I think it's really crucial that we keep our eye on that.
And you've been doing some work at the centre around forecasting future need as a consequence of COVID-19. Could you set a bit of context for us using that?
Yeah, so we wanted to really understand what does the system need to do to prepare for what's coming. There's been some I think quite unhelpful language about there being a tsunami of mental health need coming, and actually I think that completely misses the point. First of all, because people often take a very long time to seek support for their mental health. It doesn't just all happen at once. And secondly, it does treat people as a problem to be dealt with rather than people with problems that they need support for. So I think what we're really talking about, and what we're seeing from evidence internationally and looking at what we can see from what's happened in the past, particularly where there's been economic shocks, which of course is what we're all going through, is that there will be people who need more support for their mental health. There'll be people directly affected by the virus, there'll be people affected by the lockdown, and then there'll be people from communities that have been disproportionately hit by this, and people affected by losing their jobs, their livelihoods. All of those will coalesce to create increasing need for mental health support. But it won't all come at once, it will come gradually. It will. We're describing it more as a rising tide of need. And I think that's what we need to be preparing for. And so we wanted to support the system through our forecasts to really understand what they need to do now in order to be ready for that. We can't just sit and wait for needs to materialise. We need to be thinking about what's a tailored offer for people that have been in intensive care and experiencing post-traumatic symptoms. What's the offer for people who've lost someone during this time, sadly, and they experience complex grief because of the very particular circumstances. What do we want to do for young people who aren't able to get jobs and suffer the scarring effects of youth unemployment on their mental health? This is what we need to be focusing on now.
Can I say, many years ago, I was in intensive care. I took a near fatal overdose and had to be put in an induced coma for 3 of those weeks. And it was because I developed pneumonia, and I died twice. That's what they basically had to bring me back. And then when I got woke up, for the next week, I was being weaned off the oxygen and everything, and having to be lifted by a hoist from the bed to be put on the chair to sit, firm. And also when they were changing the beds, and being rolled side by side and having the attachments, and worried that they were going to get pulled out, the tracheostomy, and the sounds of the machines, and the vivid dreams, even 12 years later, it still sometimes triggers those scary things. And when the press were in ICU, and they were there and they were filming what they were filming, it did sort of take me back to a bit of a not nice place. I have never really dealt with the trauma of being in the intensive care in that. And that is a big, big worry for me, is that all those people are not going to get the support. They don't need it. They may not need it straight now or in a year, but we need to make sure that we do help them.
I think we have to recognise that this is a collective trauma, what we're going through now. All of us are experiencing it in some ways, but many people in a very heightened way. And of course, if you've had traumas before this, what you're experiencing now may bring that back to you in a particularly heightened way, as Marsha described. And so we need to understand that everyone's experiences of this will be different. And for some people, their needs will coalesce to the point where it becomes quite serious. And obviously, with traumas, part of it is about creating trauma-informed spaces so that you don't need people to go to the point where they become so unwell they need specialist support. But we do need that specialist support available. We need to prepare for it. And we need to make sure the support is there when people require it. And of course, we need to proactively ask, because people don't necessarily come forward. So we need to think about how we're equipping GPs, school teachers, employers, and all the others to just see how people are doing and provide that kind of early intelligence so that we can meet people's needs, again, rather than waiting until someone reaches crisis point.
I developed pneumonia, and so now with COVID, I'm on the clinically at risk because I've had existing conditions and that. But in the back of my mind, I remember, being in there, having to be, all of that scary stuff. And so a part of me is really, really scared in case I do get COVID, because it is really traumatic, even though I'm not at the top psychologically. It's something that sticks with me.
Yeah. So what should the NHS be doing in terms of engaging with people who use services now and have those experiences that should be taken into account?
I think that we should be preparing the workforce for almost the fallout, I hate that saying, but of what's going to be coming. For so many years, I feel that there's been so much money focused on IAT, and I truly don't think that the treatment that's going to be needed going forward is just going to be, we do need trauma-informed care. And my big worry is that we've not got the workforce that are trained for that. I just think that unfortunately we may get caught short almost because of the staffing situation, and that's no one's fault at all. But I think it's something that we've heard about, we've heard spoken and that they need to actually now do something about.
So I think that's really important. All the things we needed to be doing before, we still need to be doing. We've got record amounts of money that are promised for mental health services, so we need to make sure that happens. The only way that's going to then lead to an increase in the provision of services if we get more people in to work in mental health, and that's in all the different roles. So medicine, nursing, psychotherapy, social work, peer support, employment specialist, all of those are really important parts of the mental health workforce. So we do need to keep doing the things that we always should have been doing anyway, and bringing in people to come work. But I think it's also about actually listening to what people are saying they want, and being really attuned to people's needs as they're changing. An obvious example is that as services have shifted to digital and phone-based working, for some people that's been amazing. It's been really helpful. They've loved the fact that they haven't had to go off to a horrible building somewhere to get their mental health support. That's great. There are other people who don't find that helpful, who don't have a private space at home where they can talk to a therapist, who perhaps don't have access to the internet, or they've got a phone but they haven't got a laptop. Um, and actually it can be incredibly lonely. And so I think we also have to learn from this time about what people have found helpful, what different groups of people have found helpful, and what they haven't found helpful, and what can kind of change longer term, and what we need to kind of restore back to something like the way they were when that's safe and possible.
And we need to make sure that the consideration of what people need from a mental health perspective isn't just about mental health trusts and mental health providers. It's across the whole NHS, isn't it?
Very much so. I mean, we're doing a piece of work with the King's Fund, which we're publishing shortly, and that looks at the potential to bring mental health workers into primary care, because just GP surgeries are joining up in clusters called primary care networks. From next April, they'll be able to employ mental health workers with additional funding. That's a fantastic opportunity to bring psychological therapists, psychologists, other mental health workers into GP surgeries close to where people live, so you don't ever need to go near a specialist mental health service, but you get really good support for your mental health at a place that the majority of people find very acceptable and easy to get to. So we do need to be moving the support out there. We need to look at the various options that are available to engage people online where that's appropriate. And we need to particularly think about, I think it's really notable that a lot of the groups of people that are likely to have the worst effects of the pandemic on their mental health are groups of people that don't find the traditional mental health offer helpful. Young people, people from disadvantaged communities, people from discriminated against communities. They're people for whom the mainstream offer doesn't work so well anyway. So we really need to think about what can make a difference there. How can we build links with community-based organisations and groups that are relevant and respected in those communities to make a very different type of offer to the one that we have now.
Can I ask? It's like a question. So there's supposed to be the NHS long-term plan, and that there's supposed to be funding coming in stages. And so I'm sort of thinking, is that money already been given over? And is there going to be additional from NHS and, from the government and all that? So there's all these things sort of going through my mind all the time, sort of thinking, okay, so did the first wave of money get paid over? And because that's sort of, maybe it's like someone with lived experience who's involved with health and social care. But so I know all the various programs that are happening, but I'm sort of wondering, where is the money? Has it been given over?
I'm sure the first people that will know the answer to that are HFMA members working in mental health trusts in the first instance. Though, of course, money for mental health doesn't just go into mental health trusts, it goes into other places too. But I think that's why accountability is so important. And it's why we need to really understand what money is going in, what it's being spent on, what it's achieving. We had 5 years just coming to an end of Future in Mind, a programme for children's mental health. There's been very little accountability, very little trail for what that money's been spent on and what difference it's made. So with the long-term plan, we know the promises are real. We know that the money is genuinely going to be new money, that you don't have to make savings to get it, unlike with the 5-year forward review for mental health. But it's really important that we see how that money was spent and that it does really materialise and it is extra to what's there already. And of course, there's nothing to stop local commissioners deciding they want to do better than that. That they can make decisions now to say, actually, we need to enhance our mental health support over and above what's promised in the long-term plan. And that may be a very good investment indeed.
And you mentioned children there, and just before COVID, there was a real focus on children and young people's mental health. And I'm just thinking that, well, from a personal perspective, with a teenager myself, by September, most children will have been away from school for nearly 6 months. They've been away from their social networks and the structured support of school. Should we be thinking about things differently now for children's mental health and how they need the support they're going to need?
Oh, absolutely. I mean, this is a critical time. And I think what the surveys are telling us is children and young people and young adults are probably feeling the mental health effects of the pandemic more than any other age group. And that's partly because of not having access to school for the vast majority. It's partly because obviously they've got less autonomy, they've got potentially more worries about their family's economic situation or indeed the safety of themselves and their parents and grandparents. And very often young people, teenagers in particular, rely on peer networks to help them to cope with the ups and downs and stresses and strains of life. And of course, that's been severely constrained. And many will have experienced traumas, particularly those who are in households where they don't feel safe. And so I think that there's a really crucial thing here to be done to support schools to create safe, psychologically safe spaces for children to go back to in September. Now's the time. We can't waste any time on this. We need to really think about what that looks like. And of course, there'll be children who need specialist support, those who've experienced the worst effects of this time, or indeed whose mental health was difficult anyway. But fundamentally, we need to really, really think again about how we support children and young people to enjoy good mental health in the light of what's happened over that 6-month period.
One of the things that is in the long-term plan is they talk about personality disorder and addressing the lack of services. My worry is that borderline personality disorder, a lot of it can come back to trauma in earlier life. The stuff that I've been doing around personality disorder and trying to get funding and getting people to actually see the bigger picture, and if you start early and break the cycle, you start in children, young adults, and then the family, and it will break the cycle. So my fear is that those young children that will then go on later life to have mental ill health, and I would love people to invest the money now. As commissioners in that, they only sort of see like that part that they're going to, that one area that they're going to target. Yet with personality disorder, there's suicide prevention, there's out of area placements, there community mental health. So what I would love with this reset that the NHS is doing is to actually be bold, and they've been given the chance to do something different. So I just don't want COVID to be one of the reasons why they're not going to help support people with persistent distress. That is the key. You treat people, you take care of them. So yeah, that to me is really important.
It's an opportunity to think big and long term rather than on immediate results for investment.
Yeah, I think the NHS, I'm not sure it yet has a really detailed understanding of what we mean by prevention in many, many ways. And we know that there are huge opportunities to look at the economic, the social, the other elements that sit behind an awful lot of poor mental health and mental health difficulties. And that, of course, means working in partnership with local authorities, with community organisations, with people that are working in other parts of the system, and particularly in partnership with schools and early years services, youth services. And with the development of integrated care, there is a kind of theoretical possibility that we could really kind of up the game on prevention. My worry is it becomes very much about predicting who's going to become unwell, or very, very kind of basic level ideas of what prevention really is. And we mustn't miss this opportunity, as Marsha says, to reset and to really think about things much further upstream.
Absolutely. And many of our members have reported improved relationships with social care during the pandemic, and that's got to be a good thing. But obviously, there are still a lot of issues in social care around funding and what the future might hold. What are your hopes for social care?
Oh, so I personally have an interest in social care because I have domiciliary care, and they are the people, like I said earlier, that keep me well day in and day out. And the reason that it is because I have named carers. I have carers that are trained up, that feel supported, that have been with the organisation for many, many years. And I think that if we do invest in workforce, the carers are usually the ones at the bottom of the list that no one talks about. There's sort of been, is it the social care paper or green paper or that's been coming out for however long, that we really, really need to see during the first few months of the pandemic. We were hearing about nurse homes. What about the home carers? They weren't acknowledged. We need to sort of give them a decent amount of payment, pay them for their value, because they are the ones that had stopped people from going into hospital because they were, caring for them. And I think that as well, we need to sort of think about what the trauma that the social care staff would have had coming into people's houses, not knowing whether they were coming into, someone that had COVID. It's all that, because it's just quite worrying. We need to make sure that they're given psychological support as well.
Absolutely right, and I think there is an opportunity now to recognise that social care is the equal of the NHS. It's so often seen as being subservient to it. We only worry about social care when it inconveniences health services. I think this is an opportunity now to put that right. We're living with an oversight from the 1948 settlement, where social care was treated as second best. We still haven't changed that. We've hopefully got an opportunity with a new funding settlement to come up with something which is a whole lot better. And within that funding settlement, we need to remember that a very large proportion of people who use social care services are people of all ages who, this isn't about saving up for your retirement, saving up for when you get old. This is very often people who benefit from social care support for the whole of their adult lives, and many of them who will have done as children. So we have to have a fair system of paying for it. We have to have a system that respects the fact that it provides an equal and just as important contribution to people's health and well-being as the NHS. And we need to get over the muddle, because for many people with mental health difficulties, you've got one set of services that comes free, one set of services that's means tested. Then you've got the added complexity of aftercare if you've been treated under the Mental Health Act. It's just a mess. So we have got an opportunity to come up with something that's a lot more equitable, paid for properly, and that doesn't struggle for money alongside NHS colleagues who are doing comparatively very much better.
For me, I have to contribute towards domiciliary care, but for someone that's on benefits, sometimes I struggle to understand, whereas it's a third that has to be paid over, and I have ran up debt through sort of in the past when I've not been well, having to pay for it. And my worry is, what about all those people that don't have any money or that aren't really on benefits, or it's worrying. And I think, again, if they were to invest on the right care for people, it would save. And apart from the financial costs, the carers that come in, I have a good quality of life now, whereas a few years ago I didn't. I was in crisis point on 3 times because I wanted to die, and it was because I had 4, over the course of 2 years, I had 4 different domiciliary care companies who weren't good. And then when the council went and they sort of decided to go back to basics and start over again, and get the right groups in, or the right companies in. Those 4 that I struggled with were actually on that list. I have a really good quality of life at the minute, and I'm 44. I'm not old.
Yeah, absolutely. And the other thing you've mentioned a few times is about the voluntary and community sector and how they support people with mental health and more general health and well-being as well. But that sector's been hit quite hard by the pandemic, hasn't it, in terms of disappearing funding streams and a lack of volunteers who might be shielding or isolating themselves. And I'm just wondering what the future impact of that might be for NHS and other mental health provision.
I think what we're seeing is potentially a perfect storm for voluntary and community organisations. Many have stepped up and just without thought to their own financial situation, just said, right, we're going to help, we're going to do what we need to do, we're going to work alongside our NHS and local authority colleagues. And that, of course, is meaning that, for example, helplines have had to open for longer. Many have had to completely change the type of offer they do. For example, if they've been offering crisis cafes, they've had to move that into other ways of working in order to be safe. Some have had to invest, obviously, in protective equipment to allow face-to-face services to go ahead. Many of them have done that with very little financial security, and at the same time, of course, those that rely on fundraised income have seen very, very sharp and immediate reductions in their ability to bring money in. So they're under pressure. We're all of us as charities under pressure from every angle, and there will be a challenge to sustainability if we're not careful. We will lose really good organisations that meet people's needs. And it's worth remembering, again, many of the groups of people most affected by the pandemic are those who actually find mainstream offers less useful. Black communities of young people who are marginalised in society. Those are the group of people who are going to miss out on support if we let those organisations go to the wall. So I think there is something about, again, colleagues working in the NHS and local authorities really thinking about how can we make this safe for our voluntary and community sector colleagues who've come alongside us, remembering that the vast majority rely on paid staff, not volunteers. We sometimes mistake the voluntary sector for volunteering. And of course, there's lots of volunteering in it. And we've seen very high rates of people wanting to kind of work as volunteers and do things in their communities. And that's fantastic. But we shouldn't think that means we get it for free.
We also need to recognise that chief execs, senior executive staff of really across the board as well, we need to take care of them as well. And yeah, they shouldn't just brush off, they need to have seek support, as well, because they're only human. And yeah.
Absolutely. It's easy to put our pressures onto them and just assume they're superhuman. Are there any other lessons that we should learn from the pandemic that we should be considering and sharing with a wider audience?
I think for me, there's a really crucial issue, and Marsha was one of the people that alerted us to this, that for many people living with a mental illness, actually we've had very high levels of social exclusion, of food insecurity, of difficulties making ends meet, of difficulties with housing and money, which have always been there, but they've become very much more acutely apparent during this time. And I think that's a really important reminder that, people often talk about, oh yes, our mental health services are very holistic, or they're recovery focused, or all this other language. Fundamentally, this is about just ensuring that people can live well and have an equal chance. And I think we sometimes forget that. And this has brought it into really sharp relief that all those inequalities that were out there all the time have just become a little bit clearer. And a little bit more serious, and this is a really good opportunity to say, okay, let's make reducing inequalities something we're going to major on. We're not just going to make it incidental. We're not going to leave it to chance. We're going to really understand the kind of the social and economic realities people are living with, And that would be a really important and powerful legacy. Again, we've seen the Black Lives Movement really build over this time in response to the shocking events in the States. And we must make sure that we don't lose the importance of that for mental health, because it's very, very acute in mental health. And so, again, let's make a positive legacy that we really all take action to counter racism and racist discrimination in every bit of the system. For too long, it's been placed in a box called too difficult. We don't want to deal with this. Well, that's no longer okay. And I think we can really take this moment to say we're not going to go back. We're not going to just let this be a problem that goes on forever and a day. And we're going to take assertive and positive action to really make a difference.
And then just lastly, I would plea, it's quite important and urgent that people that are going to listen to your broadcast, that they put some funding for people for face masks, because there's people that are on low income, low bit on benefits or that really, really can't afford face masks. And if that's going to be the way forward, if you invest just a few £1,000, then you're not going to have people getting COVID, or, you just, they need to be bold and maybe spend a few £1,000 and it will save them many millions of pounds, and it will save people's lives as well.
Marsha and Andy, thank you so much for your time today. That's been fascinating. We've covered such a broad range of topics, but it's been absolutely brilliant to speak to you both. So thank you.
Thank you.
Thank you for listening to HFMA Talk. If there are particular topics that you would like future podcasts to cover, then please get in touch via our email address, policy@hfma.org.uk. Don't forget to subscribe to this podcast to keep up to date with new episodes.